Okay. Good afternoon, everyone. Thank you for coming out to Frisco High School for my final presentation. My name is Marissa Heinzel, and this year in ISM, I studied plastic surgery. So a little bit about me. I'm a senior here at Frisco High School. I've been going to Frisco ever since I was a freshman, so I've been here all 4 years. I'm a second-year ISM student. Last year, I studied pediatric endocrinology under the mentorship of Dr. John Oden. I am a big sister. I'm a huge family person. I value family over anything else. And so, family is just a giant part of my life. And I am a dog lover. For any of you who know me, I have a dog that I treat like my child. And that'll be where my picture of my family will be. And then that's a picture of my dog. Okay, and so my first year in ISM, I studied pediatric endocrinology. I'm a type 1 diabetic, and so this kind of hit home for me. I studied at Children's. It was under the mentorship of Dr. John Oden. Unfortunately, he's not there anymore. He is now the chief of pediatric endocrinology at the University of Arkansas, I believe. And so he's over there, but he was my doctor too, and so it was such a great opportunity to study under him. I also studied last year the correlation between type 1 diabetes and cardiovascular disease, and whether or not diabetes was actually a risk factor for it in younger children and adults, and if so, why it is a risk factor. And that's just a picture of me and Dr. Oden. And so throughout our ISM experience, we had to choose a quote that wanted you to guide for the whole time through your ISM journey, and I chose "You Can't Help Everyone, but Everyone Can Help Someone" by Ronald Reagan. I believe this is a main focus in what I wanted to implement this year, because I've always wanted to be there for everyone and never say no to everyone, but I need to make sure that I understand where my limitations are, and so I try to follow that. And a lot of people ask me why I study plastic surgery, and I was wondering, and I was like, I don't actually know a really defining reason, and so I decided to just Google the actual definition of plastic surgery. And so the dictionary denotation of plastic surgery is the process of reconstructing or repairing parts of the body, especially by the transfer of tissue, either in the treatment of injury or for cosmetic reasons. And this kind of showed me that I really like the reconstructive side of it, that it's not all about cosmetics that you see botched surgery and stuff like that. That's not exactly what I was into. And I also do believe that people should have a choice on how they want to look if they undergo a traumatic experience. I don't believe that that should be a burden for the rest of their lives, that they should have a reason and a way to get through it and be able to look normal and be able to go out in public without having the problem of, oh God, what are these people going to think of how I look? And also another reason I chose plastic surgery is that many surgeons have family. Like I said, I'm a huge family person, and so I believe that I need to have time for my family when I get old enough to have one, and so a lot of plastic surgeons are able to have a family as well. And so throughout the year, I had a total of 9 interviews. My first interview was with Dr. Greenberg. He was an OBGYN at Centennial Hospital, and I didn't know this going into it, but he actually doesn't do cosmetic surgery. He does it kind of on the side, but he's still, he's able to. He's licensed to do it, but his main focus is OBGYN. He said most, if not all, his patients are his previous patients. So if he has a patient who delivers a baby, then they'll come over a couple weeks later, and they'll have a tummy tuck, and he'll give them a mommy makeover. And he works in a private practice. I made it very important for me to realize whether or not they worked in a private practice or a hospital setting, because that's always a big factor. Do I want a private practice? Do I want a hospital setting? And so that's what I did pay attention to a lot of the time. My other interview was with Dr. Brost. He's a facial surgeon. He, when I was talking to him, he told me that he originally wanted to be an ENT, which is an ears, nose, and throat doctor. And he wanted to be a surgeon and deal with all that. But he said that he fell in love with complicated nasal surgeries. So he decided to go the plastic surgery route. And so he does different nasal surgeries. And he's off in a private practice. He also just started his private practice in 2003, so he was a newer type of doctor to everything. My third interview was with Dr. Chong. He's a traumatic reconstructive surgeon. He had a bunch of different stories that he told me. He He told me about one time that he had to reconstruct a lady's leg after having a 23-pound tumor removed. So the fact that it got that big in the first place kind of concerns me, but he was able to reconstruct it and have her have full functioning of the leg after that. And he also works at UT Southwestern, so he does work in a hospital setting, in a teaching hospital environment. And he was so sweet. I met him downstairs in like the coffee area, and he like offered to buy me coffee and everything like that. So he was very down to earth, and most of the doctors, if not all the doctors at UT Southwestern, were like that. And so my other interview was with Dr. Kinkle. He's a professor at UT Southwestern Medical School. He's also head of plastic surgery in the plastic surgery department. And so it was a really big opportunity for me to interview him and get to like see his perspective of everything. He works on body contouring, so he does more of the aesthetic side of everything. So if a patient is obese and they lose 300 pounds, he's able to contour their body and where they're able to look normal again, they won't have flaps everywhere. He works in both an academic and hospital setting, and so this basically shows that he's able to do both at the same time. He told me that he liked working in the academic setting because it always kept him on his toes. He was always new in research, and so I thought that was pretty interesting because research is evolving so quickly. My other interview was with Dr. Kane. When I thought of plastic surgery at the very beginning, I was like, oh, I want to work with cleft lip and palate patients. And then I get to research plastic surgery even more, and I found out there's these bunch of different subspecialties within it. And so one of the subspecialties is craniofacial reconstructive surgery. And that's kind of like, if I wanted to work with children, that's what I would want to go into, is craniofacial. You get to work with cleft lip and palate patients. You get to work with different patients that have birth defects, that their skull, the sutures in their head didn't fuse correctly, the fontanelles not right. And so they basically get to reconstruct all that. He was very straightforward. He kept me on he kept me on my toes a lot, because every time I would ask a question, he would always like tweak it a little bit, or like make me like fix the question a little bit. And so he was very analytical, but he was very educational, because he basically showed me how I had to make sure I knew what I was talking about. And then he works in the hospital setting at Children's. My other interview was with Dr. Nahara. He told me he was the bread and butter type of plastic surgeon. He said that he got 50% reconstructive and 50% cosmetic, but he also told me that he did reconstruction after breast cancer and stuff like that. So it wasn't like traumatic reconstruction or anything like that. He let me know that morals are a huge part of the field, and that I had to pay attention and not go into medicine for the wrong reasons, because that's what gets plastic surgeons the bad name, is people that go in it for vain reasons. And he works at a private practice at Centennial. My other interview was with Dr. Smart. He's a craniofacial reconstructive surgeon as well. I got recommended him by Dr. Kinkle because he was fresh out of like medical school or residency and all that, and he just got done with all of it, and so he just started at Children's. He was one of the younger ones. He was so laid back, and he loved his job, and he was just so sweet, and it was just fun to hang around with him. And he works in a hospital setting. And then my other interview, who was also my mentor for her first semester, was Dr. Stiles. She was extremely busy. She does have her own private practice, but she did make the point about the mental state of her patients. She wouldn't do surgery on the patients unless she knew for a fact that they were sound with what was going to happen to their body physically, because plastic surgery, it's more of a tangible outcome. And so you had to make sure that the patient was ready to see, and they weren't over their head about what they exactly wanted. And so, yeah. And so my mentor right now is Dr. Thornton. He is a plastic surgeon specializing in Mohs reconstruction surgery. So what happens is that patients with skin cancer who have basal cell carcinoma, squamous cell carcinoma, and malignant melanoma, they'll have defects on their nose or anywhere on their face, really, and it's his job to basically reconstruct their nose. And so he cares about his patients and treats them like family. He gives out his cell phone number to all his patients, which I thought was amazing. And he has like a huge family. His wife is his anesthesiologist out in his practice in Denton, and he has 6 kids, and so he's a huge family person, and so he has great morals, and he's just such a great person. And so he has this like great approach to how he treats his patients. So, and that's me and him in the library, UT Southwestern. And that was basically like the first part of like getting into plastic surgery and getting in and getting all my connections within the field. And so I also had to do a lot of research. These were just information I gained from articles at the very beginning where I didn't know exactly what I wanted to do, and so I just grabbed a bunch of different things that I thought were interesting. And so one of the first things I did was education in plastic surgery. Are we headed in the right direction? On the left, you see a picture of someone essentially getting Botox, it looks like. And then on the right, you have something where they would need a nasal reconstruction, and that's basically what Dr. Thornton will do. Training, in the article, explained that training is starting to become more demanding on the person, which I've heard from multiple doctors that residency is so demanding from a person, so you need to make sure that you are ready for all of it, and you have to take the commitment. But plastic surgery is becoming more accepted across the globe. It's not really seen as a vain surgery as much anymore. People are starting to see the need for it. And multiple surgeons told me that the residents, during the residency, they would focus on reconstruction and not cosmetic. Cosmetic only takes about 20% of their time. And so if you do go into cosmetic surgery, then you would have to go and do a different thing like a fellowship for just cosmetic surgery. But advancements are being made to make reconstruction surgery and plastic surgery in general just a bigger field. Another article I researched was botulinum toxin to improve results in cleft lip repair. Like I said earlier, I always thought that cleft lip and palate was that's the first thing that popped into my head when I thought of reconstruction surgery and plastic surgery. And so I decided to do a lot of research on cleft lip and palate. And so one of the articles, it said that it's the upper lip scars that lie perpendicular to the relaxed skin tension are difficult to conceal. This is why a lot of times if a child has had a cleft lip and palate surgery done to them, then you'll be able to see the skin tension within their face. By injecting this toxin, it'll decrease the wound tension. Botulinum toxin is actually Botox, so it kind of just decreases the tension. Everything's just more placid and soft. And part of the article that really stuck out to me was that ethnicity seems to play a part in the role of the toxin, which is very interesting to me. I'm not sure why, but it does. Another surgery is facial feminization surgery with different surgical techniques. Throughout the year, I always was wondering, what's my final product going to be? What's my final product going to be? And I kind of always wanted to understand different surgical techniques, why a surgeon chose the pathway that they did, why exactly they wanted to do this instead of that. And so that kind of sprung my attention. There was an article, and so I researched the article, and on the article, all the case studies were regarding facial plastic surgery for women. All women had been previously diagnosed with gender dysphoria, which is gender identity disorder. And so what will happen is that they'll have protruding cheekbones that look like a male would, or they don't have that feminine structure face and everything. So what they wanted to do is they wanted to make their face more feminine. And success stories because of the course of action chosen by the surgeon. Some surgeons wanted to go from under the jawline, some surgeons wanted to go in from the temple lobe right here, but because of the course of action chosen by the surgeon to mold the patient's needs, there was a lot of success. Also, I always kind of had the idea, I did health science 2 last year, and I got to rotate throughout the hospital. And I got to rotate through the OR, and I got to see a robotic surgery. And I thought that was just amazing. I got to see a total hysterectomy with one little scar that was going to be about that big for the woman. And that just was amazing that you're able to get that little scar after having a total hysterectomy. And so I was thinking, well, surgery, robotic, plastics, how do they all intertwine together? And when I asked Dr. Chong this, he said that plastic surgery, you won't really see a lot of robotic surgery. The main part that you'll see with robotic surgery is microsurgery. And so from that, I decided that I wanted to go look up microsurgery more and more. Robotic microsurgery, validating an assessment tool and plotting the learning curve. This was a different article. This procedure cuts down on the tremor effect, which when you're doing microsurgery, you're usually working with blood vessels and capillaries and small things like that. And so you have like 3 millimeters and you have to operate on them. And so what you want to do is make sure you don't have that tremor effect that most surgeons do. According to the article, robotic surgery is good for microscopic surgery, but plastic surgery is an art. And so for plastic surgery, you contour to the face, there's not like a straight line. And so plastic surgeons will always be in need until they can technically fix that. But being robotics, it's always kind of just straightforward and very like sterile and cut. Robotic surgery has training that the surgeon must go through and get comfortable with. It's not something that the surgeon's normally used to. You're working kind of like playing a video game compared to just working with your hands like normally. More time on the machine increase the ability to navigate, and so practice makes perfect. And so this isn't the machine that they would use for microsurgery. This would be the machine, it's called the Da Vinci. This is the machine that I was able to see last year at Health Science 3. I can hear it, yeah. We're good. We could just let it play for a little while.
Enables the Da Vinci surgeon to transcend the limitations of conventional surgical technology, making new
It's really hot.
invasive options possible for complex surgical
I think it might be
procedures.
because of my flannel and I'm nervous.
Components comprise the Da Vinci surgical
I'm talking really fast.
an ergonomic surgeon's console, a patient-side cart with 4 interactive robotic arms, and a high-definition 3D vision system. Seated at the console, the Da Vinci surgeon views a remarkably clear 3D image of the surgical field. The system scales, filters, and translates the movements of the surgeon's hands on the master controllers to 4 interactive robotic arms on the patient cart. The Da Vinci S HD system provides a magnified view that is both 3-dimensional and high definition. The result is a phenomenal, immersive experience of surgery. The precisely controlled micro-movements of the Da Vinci instruments are enabled by the computer processors of the system. These dedicated processors perform millions of safety checks over the course of a procedure for enhanced surgical precision and control. Da Vinci EndoWrist instruments are designed with a unique...
So yeah, this is completely different from what a surgeon's used to, having their own wrist and everything. They have to control it through a little probe.
This proprietary design enables surgical maneuvers impossible with conventional laparoscopic tools. As the surgeon operates at the console, the Da Vinci system filters out hand tremor and translates his controlling motions to the articulating tips of the EndoWrist instruments. The Da Vinci system also provides motion scaling that enables the surgeon to tailor the ratio of his hand movements to a corresponding micro movement at the instrument tip. The system requires that every surgical maneuver is under the direct control of the surgeon.
Yep. And so that's a little bit of an intro into robotic surgery, and that's kind of where medicine's leading to in the advancements. So what does this all mean for me? What can I take away from this research? What can I take away from the interviews? What interests me? And the major question, why? I really just find that plastic surgery in general is so amazing that you can be able to change something so tangible and be able to have such an amazing outcome that you're able to change someone's life in a way that they thought wasn't possible. And so I worked with my first mentor, Dr. Stiles, over my original work with keloids and scars. So a little bit of a background information. Keloids are scars that don't know when to stop. There's no indication when they will start, when they will stop. They just keep growing and growing and growing, and they can get really, really painful. They do not subside over time. They never deplete or anything like that. They get really red and tender. This is a picture of a keloid on an ear. Normally they appear on the ear from piercings and other things like that. And so what they'll do is they'll remove a giant keloid like that, and then you'll have to do surgery, and then you'll have a normal looking earlobe like this. And so part of my research, I did notes over 2 cases. Due to HIPAA, personal information that has been identifiable to the patient has been muted. I'm not allowed to say anything about the patient because these were actual people. And so this is patient number 1, FL. He was a male and he was 40 years old. He had keloid scars of the ear bilaterally, and so this isn't a picture of him, but that's basically what they looked like. His symptoms were just the normal pain, itching, tenderness, something that you wouldn't think much of in the first place. He went under several Kenalog shots. Kenalog shots are to see if he can take care of the keloids without actually having to undergo surgery, but the Kenalog shots did not work, and so the keloids had to be resected and treated with radiation. Most of the time with keloids, if they get on to a grander size, they will have to be treated with radiation to make sure that they won't come back. He did have a family history of keloids, which genetics I thought would be an interesting part to look over. 3rd time getting his keloids resected means that they're not going away. So this was, I think, the first time that he had radiation done to them, so they're not back anymore, because the other times he didn't have radiation and they kept coming back. But it was the keloids were so aggressive that he had to have a total of 6 radiation treatments done to actually get rid of the keloids in general. The keloids were dumbbell shaped like that, and so they had just like a little bulb sticking out there, and they had like a little bulb sticking out the front too, kind of like an eggplant looking type of thing. After the surgery and radiation treatment, the keloids disappeared. And so after having radiation treatment and after having his surgery, they finally were able to go away. He also did get them from getting his ears pierced when he was a younger boy, and then they kind of grew back his ears. The piercing went away, and so he decided to get them re-pierced again, and then keloids happened, and so again, keloids normally do happen with ear piercings. And that's just a bigger picture to see like the huge dumbbell shape right there, and being able to resect that and then create a brand new earlobe from it. My second patient that I looked over, VW, she was a female and she was 55. She had keloid scars on the abdomen after a hysterectomy. The patient did not want surgical treatment at the time. She was very against it. I mean, I would totally understand too, because after having this giant surgery done, she gets a keloid scar that essentially looked like this, but she had a vertical incision done from the hysterectomy, and so that scar right there basically was covered with that. And what happened was, when she tried to put on pants, getting dressed was just extremely painful. But she did not want surgical treatment at the time, because of course it's pretty traumatizing to have that done after the first time. So she went to seek help after having the keloids for 2 years. The fact that she was able to deal with those for 2 years is incredible to me, because I feel like that would be extremely painful from time to time. She had 3 different treatment options at this point. She could do an application of the scar healing band-aids for about 20 to 23 hours a day, which that compliance with patients for this long of a time is very rare. Patients will often forget. People that take medication twice a day normally forget their medication twice a day, so having it for 20 to 23 hours compliance is bare minimum most of the time. She could have 3 Kenalog shots 6 weeks apart, or she could have an excision of the scar and injection of Kenalog at the exact same time. She tried the metformin band-aids. They didn't really work, and so she ended up wanting surgery. Or they do work, but she didn't want to wait as long, and so she ended up wanting to have surgery. She underwent surgery and then had radiation treatment because her keloids were just extremely huge, and we just wanted to make sure that they would go away forever. She received 3 Kenalog shots and is only seen as needed now. And so basically that's what the keloids look up close, and then of course that is the vertical incision from a total hysterectomy. What helped me understand keloids and stuff like that, what kind of guided me also was the fact that I really wanted to learn about how scar revision worked and how what's the best way to take care of scars. And so from Dr. Stiles, I got different articles. The first article I got to look at was Reconstructive, a randomized control trial of the Embrace Advanced Scar Therapy device to reduce incisional scar formation. Patients and physicians saw a drastic change in how the scar healed. A Embraced Advanced Skin Therapy device is basically just kind of looks like mesh. You put it over your scar and you leave it there. Patients underwent abdominoplasties, and so basically kind of like a tummy tuck. And this is 12 months post-op is what you'll be able to see right over here. And so what they'll do, they'll lay the Embrace right over the scar. For this trial, they only did for half the scar, so you could see the before of the Embrace and then without the Embrace. And this was at the 6-month post-op. And then this is the difference between it being treated and then the controlled treated, which is nothing or whatever the physician normally does. And then after 12 months, the patient came back in and they looked over the scar again. This was the Embrace treated and the control treated, and you can drastically tell the difference between the Embrace and the control. So the Embrace does work. Another article I had to research was the analysis of surgical treatments for earlobe keloids, analysis of 174 keloids in 145 patients. There we go. I'm struggling. Keloids are most commonly seen on the earlobe masses because of characteristics of the earlobe, such as the anatomical free edges, which is this little part right here, the arc shape of the ear, which is right there, and then the lack of cartilage in your ear. This is kind of just like a little lobe that kind of just floats around. The cartilage is more of the top part of your ear, and so it has more of a structure, but because of the ending point, the little flap right there, it really doesn't have any cartilage. Appropriate surgical modalities, postoperative radiotherapy, and self-management are important to preventing keloid reoccurrences. And so it is very important to understand that radiation can be part of the treatment and everything, that you need to look into it. Even though you hear all these bad things about radiation, they do work very well on keloids because keloids are so reoccurrent most of the time. And so here are two different keloids in the earlobe. After they resected it, you have those little stitches right there. That one looks like it heals really well, that resecting it didn't cause much damage. But then you go down here and you kind of cut off the last little dangly part of the ear right there. And so what will happen is that most of the time you'll have a skin graft, or you'll do something where you'll just, the reconstructive surgeon will basically fix that. Another article I researched was the treatment of traumatic scars using fat grafts mixed with platelet-rich plasma and resurfacing of the skin with the 1540 nanometer non-abrasive laser. Patients were divided into 3 different groups. There was Group A, who was treated with the fat grafts mixed with PRP, and then the platelet-rich plasmas. And then B was treated with the non-ablative laser, and then C was treated with both procedures. Group C had an increase of 22% in wound healing compared with Group A, and Group C had an increase of 11% compared with Group B. So Group C saw the best results about how the scar would heal, and then you had Group B with a non-ablative laser, and then A was with fat grafts. And so what will happen is you'll have a patient with a giant scar or a protruding scar right there, and then you'll just treat it with the different treatments that they would have, and then post-treatment will be 6 months later, and you want something that looks more like that and less like that. All of this research will help me understand how scars heal and what's the best way to approach scar revision dealing with keloids. I've always had an interest in scar revision, and so for me to be able to research and be able to understand like why something heals the way it does and what preventative measures you can take was very interesting for me to learn about. And so that was my original work. But then I understood that I wanted to push myself a little bit further and Dr. Stiles was extremely busy due to her having to run her own private practice. And so then I went through all my other interviews and I thought, who would be the best match for me, who understands that I want to push myself further? And I realized that Dr. Thornton would actually be the best match for me. And so with him, I interviewed him again, kind of like a post interview. And then there I asked